Good afternoon. Welcome to the Autism Spectrum Advisory Board. We have two presentations today. One from Jim Kaufman from OPWDD. He's going to be presenting on using technology and communities for community sports and services. And Jill Pettinger, who will be presenting on strategies and updates of supporting people with complex needs. And then we'll have some other housekeeping after that. And always time for public testimony. But it's really great to see people in person here. I feel so bad for those who aren't here in person because it's a really good showing today. And we're just going to briefly have everybody introduce themselves because it's been a while since we've been together in person. And it's good to know if you're online, who's actually in the room. So we'll start with Alexia.
Hi, everyone. My name is Alexia Holden. I work for OPWDD Intergov and Legislative Affairs, but I also assist the Autism Spectrum Disorders Advisory Board. Nice to see everyone here in the room. Really great to have this big of a showing. And this is our student legislative assistant, Grace, who's helping out with some of the projects of the board.
Good afternoon, Jill Pettinger, Deputy Commissioner of Statewide Services at OPWDD.
Mike Tripodi, I'm part of the Self-Advocate Committee. And I specialize in areas around emergency management, disaster relief, and water safety.
Salon Myers-Strout, New York State Education Department. I'll apologize in advance. I have overlapping meetings today, so I'm going to have to leave a little early.
Hi, everyone. I'm Kristen Proud. I'm the Executive Director of the Council on Developmental Disabilities, which was formerly known as the Developmental Disabilities Planning Council.
I'm Kate Kaufman. I'm a self-advocate from Buffalo, and I'm also a New York State certified teacher and DIR floor-time practitioner.
And I believe this is your first meeting. So yeah, so welcome.
Hey, Kate, welcome. Rob Myers. I formerly was the Executive Director of the Kelberman Center. Today am the CEO of a network of Franciscan organizations in New York, Pennsylvania, and Hawaii, but continue to do this work through a couple of boards I serve on, as well as some consulting I do. It's good to see you all again. It's been a while.
Good afternoon. I'm Krista Sato, and I'm with the New York State Council on Children and Families.
Charlie Massimo, founder of Autism Communities and parent advocate.
Patrick Paul, and CEO of Anderson Center for Autism, and on the board.
Great. And if we could go to those online, and I'll, Alexia, maybe since you can see who's online, I'll let you do the call outs.
Dr. Yu, if you want to introduce yourself.
Hello, I'm Helen Yu, and I'm a research scientist here at the Institute for Basic Research, which is the research arm of OPWDD.
Thank you. Jessica James.
Good afternoon, everyone. My name is Jessica James. I'm a self-advocate who currently lives in Syracuse, New York. I currently work as an office assistant receptionist here at the Syracuse Regional Office of the Office of the Attorney General for New York State. And in the fall, I will be going back for my master's in public administration. Just a side note, I have to leave at 12:20 because I'm on my lunch break, and my lunch break goes from 11:30 to 12:30. So thank you for having me.
Thanks, Jessica. Totally understand. Josh?
Hi, Josh Mursky, proud self-advocate and also now founder and chairman of the Iron Will Neurodiversity Caucus, the nation's first neurodiversity caucus. And also, I just got a message from Steve Katz. He wants to let you all know that, yes, he's also on the board, but he is in this meeting as an attendee.
We'll move Steve over. Thanks for the heads up, Josh.
Yeah, no problem.
Kristen Thatcher?
Hi, everybody. My name is Kristen Thatcher. I am a self-advocate and on the advisory board.
Thanks, Kristen. Myla Harrison?
Good afternoon, folks. Dr. Marlay Harrison. I'm the Psychiatric Medical Director in the New York State Department of Health's Office of Health Insurance Programs, otherwise known as Medicaid.
Sean?
Hi, I'm Sean Himes. I'm a self-advocate member. I was appointed by Assembly Minority Leader Will Barkley, and I work for New York State Assemblyman Doug Smith as his district director.
Thank you. Steve Katz.
Hi, I'm Steve Katz. I'm an advocate, still a self-advocate. I run my own organization here in New York City, Speaks for Social Success, and we do all sorts of support groups and social groups and recreational events for adults on the spectrum, and I am on the advisory board.
Thanks, Steve. And then I believe Kim Perry. Did I miss you? Apologies.
I am Kim Perry, and I work for OCFS, and I'm one of the Bureau Directors for the Bureau of Children's Medicaid Managed Care.
Thanks. And I believe that is everyone online.
Okay, great. So I'm going to introduce Jim Kaufman, who I think many of you know. He's from OPWDD as a deputy commissioner. And specifically, he's the deputy director for the Division of Policy and Program Development at OPWDD. He returned to OPWDD in August of 2022 after spending the previous 14 years with the Division of the Budget. And he spent the majority of his career working on fiscal and policy matters related to mental hygiene, public health, and Medicaid. And so a couple things about his presentation today. I think you all know there are many ways that technology is being used to support people living with autism and other people living independently with disabilities. There are so many opportunities for technology to assist people and support their independence safely and in communities and in their homes. But the emergence of some new and continuingly evolving technology provides added level of depth to what is available and appropriate for people to choose from as they seek independence in their communities. So it's an important issue for us to be paying a little bit more attention to, as you all know, how quickly technology is evolving. So this presentation is going to highlight some of the ways in which the use of technology can help promote independence. So Jim, turn it over to you.
Thank you very much. I appreciate that. So again, good afternoon, everyone, and thank you for inviting me to speak today. My name is Jim Kaufman, and I am the Deputy Director for the Division of Policy and Program Development at OPWDD. Just in terms of the presentation, should I just say next slide when we're ready to move along?
Yes. Yeah.
Okay.
I don't know who has control of the slides.
Okay. So, I think that was a terrific introduction, and I think it kind of, covered many of the top points here. And before we get into specific details, later in this presentation, as was noted, I just want to take a second to recognize at a high level the use of technology, for community supports and services. As we know, technology is being used today to support people living more independently and safely within their communities. Perhaps, the pandemic served as a catalyst for some of these advancements. But we think the surface is really just being scratched in terms of, what's available and what is to come. So the purpose of this presentation is really to highlight some of the ways in which the use of technology is available to promote independence and safety, and ways in which it's expanding under the HCBS waiver. Move along. You can go on to the next slide. So just in terms of, the agenda for this presentation, and we'll move through a few key topics, but we'll cover, some of the broad sort of points here, being an overview of assistive technology, one of the things we're excited about here coming soon, home enabling supports. It's a new feature of the OPWDD HCBS waiver, and just some general information on remote support service delivery and the applicability to HCBS. Next slide. So assistive technology, or AT for short, is a long-standing support service authorized and available under the OPWDD HCBS waiver. AT covers a wide array of equipment, products, or systems that are used to increase, maintain, or improve the functional capabilities of the person and/or enhance their independence in performing activities of daily living and health-related tasks. The main purpose with this is to allow people to stay at home or live independently as they choose to. And we'll come back to that point, a few different times throughout this presentation. But relatively speaking, these are low-cost options intended to minimize the need for other, more intensive, in some cases, staff-reliant services. The AT service also provides direct assistance to a person for their selection, acquisition, or use of an assistive technology device or piece of equipment. Next slide. Specifically and primarily, AT services are for people who are enrolled in the HCBS waiver and primarily reside in non-certified home and community-based settings. These are those people who are living independently or with family, etc. In certain limited circumstances, people living in certified group homes may qualify for AT. And operationally, people may request AT services through their OPWDD Developmental Disabilities Regional Office. The DDRO authorizes AT services based on an assessed need in clinical and/or medical justification. Next slide. Just in terms of the service description and in addition to technology devices and equipment, just an important point to note is that AT may also include evaluation of the needs of the person, including a functional evaluation of the impact of providing the service and the environment in which the service will be used, assistance with purchasing, leasing, or otherwise supporting the person to acquire the devices, and training or technical assistance for the person and support needed by staff who will be assisting the person to use the device or modification. Next slide. Thank you. Examples of some of the more commonly used AT include adaptive strollers for persons who have outgrown a non-adaptive stroller but continue to need support and do not qualify for a wheelchair. Specialty adaptive locks for persons who have physical dexterity needs. Adaptive locks provide independent access to their home. Service animals, which can complete physical tasks needed by a person. Adaptive keyboards or a mouse to assist with a person's physical needs. Relatedly, communication applications. These applications are downloaded to a person's, let's just say, iPad or a tablet or computer to meet their communications needs. Adaptive eating utensils, such as a weighted spoon to address person's physical needs, or a weighted vest to meet a person's physical or emotional needs. A few of the things we do not cover include, and again, just getting back to this point, we do not purchase or allow for the purchase or the reimbursement of the purchasing of iPads or tablets under assistive technology. It's really the application that's supported by that device that will be covered. We would not purchase strollers with restraint features. Locks cannot be for the purpose of seclusion. We can cover door alarms for behavioral challenges, however. We do not cover weighted blankets. These are considered heavy and potentially restrictive. Next slide. So coming soon and trying to sort of emphasize the point here, this is something we're very excited about at OPWDD, which is the introduction and implementation of home enabling supports. Home enabling supports is a new service feature of the OPWDD HCBS waiver that was approved by CMS as part of the October 2023 waiver amendment. Some of the implementation work that is currently underway includes development of OPWDD guidance and requirements, and a selective contracting process whereby OPWDD will solicit and approve providers via a statewide application process. This will allow all regions of the state to be represented by a qualified provider. New York City may have two, given the size and scope of that particular region. The timeline we're working towards would allow for the service to be fully available by January 2025. So we're in development of many materials that we hope will be released publicly soon, which people will be able to provide public comment on. And we're hoping, although it's an aggressive timeline, we're hoping that over the next coming months, as those materials are released, we're able to fully launch this service by the beginning of next year. Next slide. So just stepping back a bit. So why are we expanding waiver coverage to include home enabling supports, and how will it support people enrolled in the OPWDD waiver? First, before getting into the specific waiver details, the expansion to include home enabling supports is in many ways a reflection of a person-centered system of choice, but also one of necessity. In a person-centered system such as OPWDD's, home enabling supports can help people live in their own home safely and independently. Secondly, however, is the reality that as the system is challenged with staffing shortages, alternative means of support will become more of a necessity moving forward. In terms of the service itself, home enabling supports is a subcategory of assistive technology, as noted earlier, already a feature of the OPWDD HCBS waiver, comprising assistive devices and/or remote support acquisitions for the benefit of waiver-enrolled persons living in non-certified homes. As noted in this slide, the waiver will support up to $5,000 per person per calendar year for acquisition of technology and devices. The intended design of home enabling supports is to decrease the need for other Medicaid services, minimize the need for on-site staff supervision and intervention, reduce dependence on staff, improve the person's opportunities to live in communities of their choice, increasing a person's health, safety, and dependence in their home environment. Next slide. So who can receive home enabling supports? Home enabling supports are for persons who live alone or with their family or with roommates who may or may not have disabilities in non-certified residences. Through the person-centered process, goals related to independence, safety, and meaningful community participation that can be met through the provision of the home enabling support service should be identified in the life plan. Home enabling supports are not for persons residing in certified home and community-based settings, such as individual residential alternatives or family care homes. Next slide. So getting a little bit into the specific types of technology. Home enabling supports, as noted, provide the option of acquiring assistive technology devices. Assistive devices are devices that are designed, made, or adapted to assist a person to perform a particular task. Some examples include smart home technology. This could be voice-activated lights, thermostat, things of that sort, a sensory pad, the types of things where maybe a person enters a room and there's a technology or a device within that room that senses or understands that somebody has entered, and it turns the lights on, or it moderates the temperature. It could also be safer cooking appliances, such as induction stoves. Next slide. So the purpose of this slide is to kind of highlight the two main paths of home enabling supports. As noted in the previous slide, home enabling supports can very much be devices, equipment, smart tools and applications, etc. And there's many possibilities. The slide only touches on a few of them. But it can also be remote supports. These are subscription-based services accessed through a vendor located outside of the home, meaning the service itself is located outside of the home. To be more specific, remote support is the provision of supports by a vendor that subcontracts with the home enabling supports provider. The vendor is located at a remote location and uses an electronic method and equipment to engage with the persons who have the capability for live two-way communication. And it's really important, some of those words. Engage with live two-way communication. This is intended to be interactive and very much prompted by the person who has acquired the home enabling support. It is not in and of itself a monitoring mechanism. Some examples include subscription-based services, again, two-way, real-time communication using audio and or video technology to allow the person to interact remotely with others for assistance. Motion sensing systems, radio frequency identification, and also health access and coordination services. Now, this is in and of itself its own type of service technology, but it is related and it can be covered under the home enabling support service. It's a teleservice that is used to treat emerging medical issues and limit or avoid emergency room or medical visitation. In terms of accessing the services, nonprofit agencies on behalf of the person will purchase the technology and services needed to achieve the goals outlined in the life plan and address any rights modifications if needed. So again, where we have technology or services that are coming into a person's home, to the extent any of them would be viewed as potentially restrictive, that would be built into the life plan. Next slide. So that was a lot on assistive technology and home enabling supports, specifically ways to bring technology into the home setting. But we wanted also to touch on how technology may be used to deliver other waiver services. The important point to highlight, once again, is the OPWDD waiver requires person-centered planning and is administered consistently with the HCBS settings final rule. The HCBS settings final rule, which was published back in 2014, became effective and in full effect on March 17, 2023, establishing new standards for approved HCBS settings. The final rule specifies that all settings where HCBS are provided and where HCBS recipients live must be integrated in and support access to the greater community and selected from among options by the person. It's also important to note that during the COVID public health emergency, however, additional flexibilities were provided, and certain flexibilities remain in place after the expiration of the public health emergency. Flexibilities were allowed via what we call an Appendix K provision through the HCBS waiver, which was used by many states, including New York, during emergency situations, requesting specific amendments for flexibility to their 1915C waivers. As it relates to remaining flexibilities for remote technology, those include community habilitation, pre-vocational services, day habilitation, pathway to employment, respite, and supported employment. Next slide. So just expanding a bit on this point, in addition, the final settings rule regulations identified new requirements for the person-centered planning process and the person-centered plan to strengthen people's rights to make informed choices about the services and supports they receive. It's important to point out that both residential and non-residential settings must use person-centered approaches. And once again, during the PHE, many flexibilities were allowed, including a number of waiver services that could be delivered using remote technology. This was a necessity given the health and safety concerns associated with person-to-person interactions, as well as limitations in capacity to attend day programs, staffing challenges, etc. Next slide. So the public health emergency related to the COVID-19 pandemic has officially been declared over. The Health and Human Services Secretary ended the COVID-19 public health emergency on May 11, 2024. Flexibilities that were authorized under the Appendix K for HCBS waiver services during the PHE expired on November 11th, 2023. That was a 6-month unwinding period from the end of the officially declared end of the PHE. On this slide, you'll note a specific administrative memorandum that has been updated and released by OPWDD. That is 21 ADM 03R. You can find that on the OPWDD website. The ADM referenced here relates specifically to the ability to use technology for remote delivery of HCBS services, specifically HCBS services which may be delivered remotely that are intended to have a long-term service delivery option for the person, defined as the need for services for a non-emergency basis for more than 30 days. The use of remote technology to provide services must be identified in the individual's life plan and supported by the evaluation of the technology. Next slide, please. So, as noted previously, which services, and again with certain limitations, can be supported with a remote technology? That's rehabilitation, and it's important to note, however, that this is only available for people who live in non-certified residential settings. Community habilitation, again, to note, in-residence ComHab for people in certified settings is only available for those who are elderly, medically frail, or present significant behavioral health needs, and it must be chosen by the person. If a person chooses to attend in person a day program, they should be afforded that choice. Pre-vocational services, supported employment, pathway to employment, support broker, and respite services. Again, a person-centered focus, and it's important to note that remote service delivery cannot be the only modality used on a long-term basis in delivering services to waiver participants. The use of remote technology to deliver services is determined through a person-centered planning process and is initiated per the person's request. The use of this modality may be part of an individual service plan along with in-person services as described in their life plan. And I believe that concludes this presentation, and I was not able to monitor the chat as I was going along, but if there are any particular questions, I'll do my best to answer those.
Thanks. Thank you, Jim. I can't see the chat, but I did have a couple different, I don't know if you call them comments or questions. The first was about what you said regarding where technology, home enabling technology can be used. And I was surprised to see that it was only in non-certified settings. I could see instances in certified settings where it might still be applicable. So I don't know if that's probably a federal rule. So I should just ask that question. Is that federal or is that a state decision?
I would describe it more as a state decision, but also one that aligns with the existing HCBS waiver. So I can't recall if I specifically made this point, but the home enabling supports was introduced into the waiver and approved in the waiver under the assistive technology subcategory. It is possible to bring assistive technology into a certified residence. That occurs in very limited circumstances. Assistive technology and thus the home enabling support feature is by design of the waiver to be used primarily in non-certified residences. So again, specifically a low-cost option that assists people, to live in their own home with their family, with other roommates of their choice, etc. Now, that's not to say that there cannot be technology utilized and leveraged within a certified residential setting. We know that there are a number of innovative ways in which certified residential settings are using technology. But as it relates to this specific service category within the HCBS waiver, it is specifically intended for the non-certified residents.
Okay, thank you for that clarification. That is helpful to know that it still can be used in some of those certified settings, but It's a matter of categorization. The other question I had was related to the $5,000 a year limit that you mentioned. I could see some circumstances where it might actually be cost beneficial for somebody to have some type of technology and it might exceed that $5,000 limit. I was wondering if there's a way to perhaps on a case-by-case basis review that threshold amount if it turns out to be cost beneficial.
So two things. It is defined in the waiver as a $5,000 limit, but within the broader funding threshold of the assistive technology category. As it stands, the assistive technology category does have thresholds, but it does have an exemption process. That said, so that we are able to ensure some parameters around the limitation, I shouldn't say the limitation, but the implementation of the program. These parameters are set in the waiver. The $5,000 limit is intended to be an offset within the broader assistive technology category. At a later time, the waiver is also allowing for limits to be set on the assistive technology category consistent with the full use and expiration of ARPA funds. So I think the way to answer that question is, while it's a $5,000 limit, it does exist within a broader funding category of assistive technology. Okay. But part of the point of that is, with it being a new service, it was important to be sort of careful and somewhat limited in our introduction of it.
Okay, I appreciate that. I was going to see if there were other questions or comments from people in the room. All right, we have two. So Charlie, you want to go first and then Kristen?
Sure. Thanks for that presentation, but just one follow-up on the clarification of Courtney's. Is it $5,000 per individual or $5,000 per home?
It is. I'll have to, don't hold me to exactly what the waiver language says, although, but I believe the language supports this, but it's intended to be a $5,000 funding threshold per person.
And then the second, you mentioned that in the life plan it has to describe that technology is needed. Who actually does the evaluation of what technology is needed?
So this is sort of the under development aspect of our process now in terms of guidance, as well as provider manual. But it will entail an evaluation both from the care manager supporting the person, their family, that person, and staff from the selected provider agency.
So thanks a lot, Jim, for that presentation. It was really interesting to sort of hear the range of things that can be available under the waiver. A question about home enabling technology. Are there any security related features that can be covered under the waiver? I'm thinking of devices, for example, that alert people if they have not closed a door, they have not locked a door, those kinds of things. We happen to have a council member who got funding, not through OPWDD, but through separate sources, to do some home modifications. And one of the things for her that was important, because she lives alone, she does have support staff, but not 24/7. One of the things that was important to her, and she does admit readily as she's aging that she gets forgetful, like a lot of us do, but she was concerned about her personal security and safety, and so she was able to purchase some security features for her residents to ensure that she remembers not only to close doors but also to make sure that the doors are locked. So I would really encourage OPWDD to make sure that that category of home enabling technology is accessible through the waiver. I'm really happy to see service animals listed. And I'm wondering if there are certain things that are covered or excluded with regard to service animals. I think service animals are properly trained with the individual who has the service animal also trained with the animal can be incredibly valuable, both as a physical means of physical assistance and also, of course, of emotional assistance. And I think there's a really great and growing body of research out there about the benefits, both for physical and emotional assistance that service animals can provide. So I would just encourage a broad interpretation of what can be covered under the category of service animals. And then with regard to the flexibilities you mentioned that were in place throughout the COVID public health emergency, are there any categories of those flexibilities that have gone away now that the PHE has expired just about a year ago now, and the wind down period is also over?
Yeah. Those are great comments and questions. I'll start with the very last one and just note that, I think what went away in terms of the flexibilities that existed during the PHE is really around the day programming aspect. And it was noted, I think, the services were highlighted in a previous slide, and I think I verbally noted, that with respect to day programming services, day habilitation, that is only available post-PHE for those living in non-certified residences. As it relates to community habilitation, that is now post-PHE only available, for those living in certified residences, that is now only available for those, one, choosing to have in-residence ComHab, but two, also those presenting either elderly, medically frail, or significant behavioral health needs, and again, based on their own choice. So I think those are the primary sort of flexibilities, and specifically around day programming, that did moderate post PHE.
Jim, can the category of medically frail, does that include those who are immunocompromised who should not be in larger settings? The advice of their medical team.
I'm just going. I unfortunately I couldn't tell you. I'm not the expert on exactly what the parameters would be around determining that medically frail. That's something that would be determined.
In other settings, we see that as one of the lingering elements of COVID, right? The pandemic phase is over. We're now in the endemic phase, but there are individuals out there who are immunocompromised, who continue to be immunocompromised for a whole host of reasons, whether it's because of certain medical treatments that they're receiving or because they have underlying chronic conditions. And I would just encourage OPWDD to be mindful of that. Because certainly, even though we're now in the endemic phase, there are individuals out there who are trying to be, and family members of individuals who are immunocompromised, who are trying to be as protective as possible to avoid the spread, not just of COVID, but other respiratory issues as well that are prevalent.
That's very helpful, and certainly we'll make sure people are aware of that point. Great. And I did just want to touch on the first questions with respect to security. Two things in the waiver specifically includes language around full HIPAA compliance. So there's that sort of personal information and health information security feature. But as it relates to security and the use of technology for security, the answer is yes, but as noted, to the extent, so let's just say, for example, a door camera, something that would, basically allow a person to view their outside or external environment from inside their home as a matter of safety. Yes, to the extent, and there are likely to be other security related features. those have to be evaluated in terms of potential rights restrictions, and it's not to say that they wouldn't be allowed. I think the point is that they would be with the potential rights modifications, outlined in the life plan.
Thanks for that.
I'm sorry, I don't mean to interrupt. But I have this thing in my apartment that is called Simply Home, and it can actually tell you if the door is open or if you gotta open the door and you have to lock the door. It actually reminds you to lock the door. It also does it does a lot of other safety things. It's called Simply Home. I think you have to look it up, more information, but I don't know a lot of, I know a lot about it because I use it. So yeah, that's been a really help. And my other neighbors in my apartment building uses when he opens the door to leave, it says, please lock your door. And I think also if the person decides to have it, make it make it to say, remember, lock your door when you're coming in. I don't know. So yeah, that's what I know. That's what I use to help with safety and that kind of stuff. Oh, and it also does fire if your stove is on, all that other stuff like that too.
That's great and helpful to hear that. Thank you, because I think those are the exact types of things we're talking about. And so whether through assistive technology, home enabling supports, some combination, those are the types of features, that we're hoping to allow people to bring into their home environment, and help their sort of needs for independence.
I think we had
So
three more
thank
questions or comments here. Mike, Rob, and Chris. We'll go in that order.
All right. So are there any emergency provisions in this? So like, for example, if somebody's has spent the entire $5,000 putting in, their systems, and then they have like a fire or other disaster. This is something that I definitely encounter all the time, where people lose their assistive devices, and it's very hard to replace them because they've maxed out what they can do for that year. So is there any kind of emergency provision that, say somebody puts in a whole home, Ring camera, stuff like that, they have a fire, where that could be replaced due to the emergency circumstances, kind of like what SNAP does. SNAP will actually give you money to say, okay, you've been through a disaster, here's a little extra boost to get you back whole.
Yeah, it's an excellent point. And once again, I would just say that's sort of very much in, our current guideline and provider manual development phase, but it's a good point. And yes, we are talking about, assurance of replacement, even technology refreshment, things that, may become outdated over time. So those are very much a part of our, current discussions. Nothing, of course, is finalized at the moment, but, I've made note of that particular point, and I'll make sure that we're talking about this as specifically as you just described it.
Yeah, I have a comment and a question. The comment's pretty quick. Years ago, we had a Medicaid infrastructure grant, which, of course, it's a lot of that I probably don't want to talk about, but Syracuse University at that time had a relationship with the Coleman Institute at University of Colorado, which has put a lot of this work forward in ways that are very easy to digest, the different paths of technologies. And it comes very much from a rights-based perspective. I think it's helpful for some of us board members. I'm sure they're experts in that stuff. But committee members, their website's a great resource. So just that comment. But my question really is there a provision, if all the policy and all the ADM is met, can an individual have, I think you call it two-way communication? Can two-way communication be utilized in a way that replaces direct support, or at least allows those direct support dollars to come into concert so you can exceed the $5,000 cap? Because I'm kind of imagining in simple terms, I'm somebody living at home, I need this kind of technology, I might need it full time for a year, or at least have needed for a year, and that cost would very quickly exceed $5,000, but it would be replacing direct support in my budget. So can I do that?
So the home enabling supports is intended to lessen the need for other Medicaid services. The $5,000 limit, and again, that's specific to, the type of support you're describing, a two-way, subscription-based feature. I think it's something to talk about, and, it's come up a few times, and, we'll make sure that we're thinking through, what type of sort of fungibility may exist within the broader funding category. So I'll make sure that, that point is brought back.
Hi, I also had a question and a comment. You mentioned that there's a variety of HCBS services that can be delivered remotely, including community habilitation and respite services. I was just wondering if there's any parameters, just recognizing that the benefits of ComHab and respite include, providing some on-site, in-person services and supports in the home and in the community. And I was just wondering if there's any parameters on how those services are being delivered remotely.
Just so I understand, parameters specific to assessing or evaluating how those services are being remotely or delivered remotely?
I was just curious. We work with a lot of young people and children and youth and families that very much are in need of ComHab and respite services, often, in need of those services in the home and in the community. And I'm just wondering, how do you use assistive technology to engage a family and a youth in delivering those services remotely versus in person?
So just to be clear, I mean, those while a technology obviously allows for the remote delivery, a screen, a device, a tablet, a computer, etc. The assistive technology is a separate categorical sort of service component of the waiver. But I think, the broader point is, if applicable, and, the best and most effective way for a person, to be delivered a service, and it is remote, again, under certain circumstances, that is available. And so understanding that, everyone's circumstances are, of course, different, just, in some of the ways you described as well. It's really up to a person who is enrolled in the HCBS waiver to document those things within their life plan so that it's all being done, again, if applicable and as available, pursuant to their own choice and their needs.
Well, I don't see any other hands up, so I don't see any hands up online. So Jim, we really appreciate the conversation. Very excited about more use of assistive technology generally for people. So thank you.
Same here, and I just want to say thank you to everyone as well for listening, and the comments and questions were very helpful. And as noted, we'll certainly take the points that were raised back as we work on this.
Great. Thank you for allowing us to have the input today. And
Okay.
All right, well, we're going to switch subjects. So I'm going to turn it over to Dr. Jill Pettinger.
Right, thank you. Okay, so I'll be doing some updates today on strategies to support complex cases. And I just want to acknowledge my appreciation for being here today to provide some updates. I will also be calling out to Sarah Kirikos from OMH to chime in from time to time, since we have a number of cross-agency collaborations that we're working on, some of which I'll be referencing, and some of which we can or cannot talk about a great deal, depending upon where they might be in various stages of RFPs being out and things of that nature. So Anyways, I also just want to acknowledge that April was Autism Acceptance Month, a month that until recently was referred to as Autism Awareness Month. And I think today, I think we would all agree that we've moved beyond general awareness about autism and striving now instead to work towards acceptance and understanding. And that's an incredibly important shift. And it certainly influences how, as I'm talking about our strategies supporting complex cases, individuals with autism spectrum disorder may often present some complexity to their support needs. And so again, we need to make sure that we're capturing supports that address their continuum of needs just as much as any other person with any type of developmental disability. And we also know that while the characteristics of autism are not always visible, it often impacts people's lives in ways that we really need to keep striving to understand. And OPWDD is certainly committed to increasing acceptance and understanding of autism spectrum disorder. So I'll just start with that in mind. And next slide. We know that people with complex needs do require a complex approach, yet our system of care is primarily designed for people who have a clear path and who do not present with a lot of complex needs. That's been sort of our history, is that we have a one size fits all kind of system, and we're really being challenged to really diversify our portfolio and our understanding of how to meet people's needs across a much broader continuum of support needs. And we know that all over the state, there are New Yorkers with complex needs that are experiencing challenges like discharge delays from emergency departments and inpatient units, some people being there for months long and might I say a year long lengths of stay, which is just not acceptable. We understand the strain that this is putting on hospitals, that broader system, as well as the stress certainly that it's causing for the person and their families. These are really complicated problems that we need to continue to problem solve around. We also know that people who experience extended hospital stays can see a decline in their functional status. It negatively impacts psychological well-being, especially for older adults and children, all of which are especially disruptive to OPWDD's mission to help people achieve higher levels of independence within their communities. Unfortunately, the solutions to these very complicated problems are also very complex and require a real cross-systems approach to navigate the barriers that we've all experienced to providing needed supports and services to those with these complex needs. Next slide. Okay, so the other thing I would just want to acknowledge is that we've seen a rapidly growing number of children seeking OPWDD services, and this has underscored the need to find innovative and collaborative ways to handle complex case care. Right now, we're seeing that children under 21 make up roughly 1/3 of the people served by OPWDD, and this age group is growing nearly 40% faster than our service population overall. So there has been an increased need to serve children in crisis who struggle to access appropriate emergency supports. And so again, when you see this kind of change in the profile of who we're serving, we as a system have to be paying a great deal of attention to this because it needs to result in changes to not only the continuum of supports, but also some of our areas of focus. So these are all things that we are examining, as you can imagine. As part of OPWDD's 5-year strategic plan, the agency has undertaken several initiatives to improve the services available to children, youth, and young adults. And these initiatives include expanding capacity for specialized treatment, engaging in more consistent cross-systems dialogues, and working to improve coordination of services between state agencies. The agency's goal is to have a continuum of crisis supports that are responsive, available, and easily accessible to people with developmental disabilities and their families across the state. We need to proactively support people and work collaboratively with the other systems to address the needs of those with more significant behavioral challenges before they become a crisis. So hopefully you're hearing a couple of themes, and that really it's focusing on that cross-systems engagement, collaboration, and really building additional strengths and capacity across the whole service system. OPWDD cannot achieve this alone, and we really have to be working closely with our partners across the state with other state agencies and counties, et cetera. Next slide. So I'll just give an update on CSIDD here, and then I'll provide another update in a little bit related to some special pilot project that we've had in play with some ARPA funding. But just in general, for adults and children aged 6 and older experiencing crisis, OPWDD has implemented crisis services for individuals with developmental disabilities, known as CSIDD. And this follows the National Systemic Therapeutic Assessment Resources and Treatment, or START model. Sorry to speak in so many acronyms, but these names of these services are too long to just say them all each time. So we have our acronyms. CSIDD does provide high-intensity services for people who experience frequent hospitalizations, crisis visits, use of mobile emergency services, and who are at risk of losing placement and/or other community services that they've been engaged in. Based on their clinical needs, adults who are enrolled in CSIDD may also access what is known as the Resource Center, which is under this the CSIDD umbrella, which offers both planned and emergency site-based therapeutic support. Resource centers provide assessment, systemic supports, and services with the goal of having the person return successfully to or remain in their home, and it will soon be a resource that's available across all 5 of OPWDD's regions. The Resource Center team is closely linked with the CSIDD clinical team and includes evaluations by the CSIDD medical and clinical directors. So again, there's a rich clinical resource available through this program. And again, it's important to note that after 10 years, actually more than 10 years when you count the planning time, because I was involved in when we originally brought START to New York State, it's basically 10 years of planning and implementation now that we've achieved full coverage of CSIDD across all 5 regions. So we now have providers in each of our 5 regions, 2 in New York City. And we're working now on where we can start to target some quality enhancement measures to further strengthen the service. It is not perfect. We know there are challenges, but I think with full statewide implementation, we have an opportunity now to sort of learn what has been successful about the model, where we need to continue to address gaps and further strengthen connections with the other continuum of supports and that system connection that I was referencing earlier, because CSIDD does not operate in a vacuum. It really is a systems model, and it is dependent upon that interconnection with other existing resources and supports throughout, not just OPWDD's service continuum, but the mental health continuum, other resources at the county and local levels, et cetera. So that's really important. And again, we're really taking a look now at the quality of the program and how we can continue to make those improvements. Yeah. They have to be DD eligible. Yep. So we'll start there, but it's a state plan. We've created a funding mechanism that is a state plan service. So a person does not have to be HCBS waiver enrolled in order to get the CSIDD service. If they're going into the resource center, they do, because again, that ties into the funding mechanism, because the resource centers are essentially framed out as an intensive respite setting. Okay, so that has a little bit more nuance, and that's targeted for adults, not children, for the resource center component. So good question. But yes, CSIDD is available to people who are IDD eligible, but not necessarily waiver eligible. All right, so next slide. Okay. So we recognize that we have an urgent need really to find multi-system solutions for the growing number of people who are not neatly fitting into one agency service system. And we're actively working to develop cross-systems initiatives that prevent people from falling through the cracks between the different service systems. And this is, as you can imagine, not a small undertaking because every system is very siloed. I think we're all familiar with that. If you've worked in the system, no matter what agency you're at, it's very easy to stay stuck in your silo and not reach across the hall and understand what may be happening in a sister agency. So we do participate in regular meetings, for example, with the Conference of Local Mental Hygiene Directors or CLMHD and the Interoffice Coordinating Council. We also have had for several years now an ongoing cross-systems deputy commissioner work group that's convened by the Council on Children and Families, includes us, OPWDD, OMH, OCFS, SED, Department of Health, and a number of other state agencies. So that's been a really very engaged cross-systems group. And really the focus of all these interagency types of groups is really to focus on expanding capacity for specialized treatment, engaging in more consistent cross-systems dialogues, and working to improve coordination of services between the state agencies. Again, because people can have needs that cross multiple state agencies. It's not just limited to one in many cases, particularly when you're talking about those with more complex support needs. So we are specifically working on a number of cross-systems initiatives to address complex needs, and I'm going to give some examples of those now. Just one I'll reference quickly, the Council on Developmental Disabilities, formerly DDPC. We had a pilot proposal with them, with OMH and OPWDD. Had partnered and received some grant funding from the Council on Developmental Disabilities to create two home-based crisis intervention teams specifically focused on youth in crisis with both a mental health challenge and developmental disabilities. And HBCI is a short-term intensive service that serves youth and their families when the youth is at risk of psychiatric hospitalization. The program includes a family preservation component and intensive intervention, all within that family setting. So it truly is a home-based service model. And again, the pilot was really to focus on building out additional knowledge, skills, and capacity to serve a youth who has a dual diagnosis with that model. So that is a pilot. It has been awarded. We had an RFP process that we worked with OMH on. So that's great. So that's currently underway. And since that RFP was issued and that project started, it's also exciting to note that OMH did recently expand in a broader sense their home-based crisis intervention RFP across more counties and regions. So, and Sarah, I don't know if you want to say anything, but that's just sort of a FYI. It's currently out for RFP, so we can't talk a lot about that. That one we can talk about? Okay. Okay.
The procurement record is not finalized, but been notified. So this has been a really exciting project, and for the developmental. I don't know if you're familiar with the idea is that that there are some periods where really very daily, maybe multiple, make sure that young person. A lot of times on the non-dual side.
I just want to interrupt to say we cannot hear online.
Thank you, Mila. Is this any better?
Yes, thank you.
Okay. Well, thanks. I appreciate you noting that. Okay, I'm going to start over, but not be as wordy. So on the, for those of you who aren't familiar with the kind of quote unquote traditional home-based crisis intervention model, it's based on the home builders model. And the idea is that there are periods of kind of acute crisis where having a very, very highly intensive, nearly daily touch point can make a difference. And so typically an interventionist in the home-based crisis intervention team would only be supporting one or two families at a time. So that leaves them the ability to come in maybe every day, multiple hours a day as needed. A lot of times we see this with like a period of school refusal, you know, a traumatic incident, risk of hospitalization, et cetera, where someone who can really kind of be on call in a 24/7 hour way makes a big difference. What we worked on as a innovative model, including with the home builders team a bit, is the idea that for young people with developmental disabilities as well as the mental health diagnosis, that there is both specific training, probably a little bit of a longer length of stay, probably a little bit more of an intense staffing model. And with the support of the council, we did a rollout in 2 OMH regions. You know, the pace of everything is that we're just getting these teams going. But while we had additional funding, we also wanted to make sure that we did the opportunity to put a pilot team in every OMH region. So that is 5 teams. I understand all 5 have been awarded at this point. So what we'll be doing over the next year or 2 is collecting the data on that and look to see if it supports a further expansion beyond those catchment areas.
Thanks, Sarah, for those additional updates. So again, you can see the partnership in action here between the 2 agencies. It was a lot of work to get that off the ground, but I think it's going to be really great to see what the data tells us as they begin implementation. The other thing I just wanted to mention is I think folks are familiar, I think I may have talked about this in the past, with the Specialized Residential Treatment Facility, or RTF, that we started as a collaboration project with OMH back in 2018. It's when they opened at Our Lady of Victory Services. And this residential treatment facility, again, is an intensive treatment program model. It's intended to serve individuals who are duly diagnosed with IDD and a mental health diagnosis or serious emotional disturbance. And we have been partnering on that project. I think we've had some really successful cases go through this particular intensive treatment program. We've had challenges on the discharge planning side in some cases because of staffing availability for some of the services that individuals might need once they leave this intensive treatment program and return home. So COVID has obviously continued to have an impact on staffing for many types of programs and supports and services across the spectrum of agencies. It's not limited to OPWDD, but I think that despite some of those challenges, we've had some real success stories for cases that have gone through this program. And something that we're currently working on now that would sort of further expand the model has to do with work that we're doing currently with OCFS and Department of Health to really create a pathway for children and youth who are in foster care to be able to access this particular intensive treatment program model, because right now it has precluded youth from that who are in foster care from access. So again, because it started as a pilot project, we started with a very focused population initially, and now we're working to create the framework to support on the OCFS and Department of Health side, the discharge components that would be necessary for youth who goes into this intensive time-limited program, that when they go back out to a foster care program or perhaps returning to their family of origin, that there are the resources and supports in place that are, again, going to wrap around that youth to help them be successful with that transition back to a non-institutional type of setting. So again, this is work that we've been undertaking with OCFS and DOH, and I think we're pretty close to finalizing that pathway. So we're excited about that. And of course, we always explore how we might be able to replicate this program model in another RTF location somewhere in the state. We haven't quite figured that out yet, but nonetheless, it's still on the table, I think, for discussion because it has been successful for a number of youth. I just also want to provide a quick update on the SUNY Upstate program. We've been, again, partnering with OMH in the development of the SUNY Upstate specialized essentially a specialized multidisciplinary inpatient program that would be intended to support children age 11 through 17, duly diagnosed with a developmental disability and a mental health disorder. This program, again, is more of a specialized setting intended to provide crisis stabilization and very specialized psychiatric and behavioral treatment with a focus, again, on safely returning children to their family home with appropriate wraparound supports and services. So I think folks may be aware on the adult side, we had already started a program, an adult specialized inpatient unit down at Kings County Hospital, again, working in partnership with OMH on this project. We have a step down program to that program that is operated by OPWDD. So that's been, again, a successful model. And our intention was always to develop a children's version of this with Our Lady of Victory, the specialized RTF that I mentioned being one aspect of that step down continuum. Unfortunately, it just took us a bit more time to get the inpatient program component figured out. But I think we're close. At this point in time, it's looking like that upstate program could open in the fall. We've been doing a lot of other work to also support upstate medical around an intensive outpatient program model that they will have as a companion to the inpatient program, and a respite component that would support those children who are at this point OPWDD eligible, who would need respite, because again, it will fall under our current intensive respite model, site-based respite model, that would essentially provide a place for that youth to stay while they're attending the intensive outpatient program component. So again, trying to create that continuum of care, stepping someone out of an intensive inpatient setting to an intensive outpatient setting, and then transitioning back home with appropriate supports to the family to continue the success of their child in reintegrating into the home. So again, these are very specialized programs, but again, when I talked earlier about complex care needs, these are the kids that are getting stuck in hospitals and emergency departments that we have difficulty getting access to, even when identified as appropriate for residential school referrals, those residential schools feeling like they're not quite stable enough for them to receive them into their settings. So again, we've been really brainstorming and working hard to come up with a stronger continuum of care that will help to, again, fill some of these gaps. It's not going to impact thousands of children, but is impacting a small number of very intense cases. And again, these have been the ones that kind of get stuck. So I'll just pause quickly. Sarah, do you want to add anything else to the specialized inpatient or the intensive outpatient step down?
No, not.
Okay. All right, great. Okay. Let's see. We've also continued our partnership again with OMH on the 988 rollout, and really the focus there being to ensure access to crisis services for people with developmental disabilities who may contact the newly designated 988 hotline. Project ECHO was a companion partner project and training partner for the program to ensure that the needs of people with IDD were understood by hotline operators so they can triage calls more effectively. So again, that's been a multi-layered kind of project that we've been working on with OMH, and really focusing again with that Project ECHO. I think I said Project Teach. I apologize. I meant Project ECHO. That project really building on New York State's ongoing efforts to create a more robust learning environment for the crisis workforce. So again, I think we've seen some success. There's been a number of cohorts that Project ECHO has engaged with the 988 crisis workforce, and really, again, focusing on areas around developmental disability and how that having a need to understand population needs more in depth, and having more knowledge and capacity to effectively then respond when they're getting calls from people with developmental disabilities. Again, I think has informed and improved the skills of that particular workforce in terms of what their role is in the system continuum. The other thing we've worked on, because we had the benefit of American Rescue Plan funding, was we collaborated with the New York State Council on, Conference of Local Mental Hygiene Directors to do some gap analysis and to then basically pilot a specialized enhanced mobile crisis model. And through that effort, I have some great data that I can share with you. So we did enter into this contract with CLMHD to really figure out a way to implement a new mobile crisis model to better triage and manage crisis cases for individuals, again, duly diagnosed with a mental health need and intellectual or developmental disability. Because we know that historically, individuals with IDD, including children and their families, were continuing in patterns of crisis because the traditional crisis service responders, such as mobile crisis team, other first responders, did not have a very relevant training or expertise in working with those folks. And so we were finding that this lack of expertise at the county level was leading to much less effective crisis de-escalation, a lot of leading to a lot of misunderstanding and further exacerbation of the crisis. So things weren't getting resolved, they were being made worse, sometimes by the mobile crisis response activities. So it wasn't working, it was ineffective, and it resulted in more costly service continuations playing out. So the pilot model that we were able to support with ARPA funding was referred to as the Collaborative Mobile Crisis Response Team, went live in February of 2023. The pilot paired 3 OMH certified mobile crisis teams in Erie and Wyoming counties with clinical IDD expertise through our regional CSIDD team. And the CSIDD team supported mobile crisis via remote technology to assist with the assessment, identifying critical behaviors, environmental factors, and mental health issues that were contributing to the crisis situation. CSIDD also assisted in formulating and implementing a crisis stabilization plan, including coordination of additional face-to-face intervention when it was needed with the individual, the family members, and or the staff. And the CSIDD also assisted in developing a follow-up or aftercare plan with the appropriate referrals. So again, by linking the mobile crisis responders with the CSIDD team, we were able to infuse more focused knowledge and expertise around IDD specific issues and how to triage the case a little differently as a result. And we have some really great data that we were able to learn from this project. So for the first 10 months of the pilot, the enhanced mobile crisis team responded to 72 crisis events attributable to 68 different or distinct individuals. And of that number, 65% of those crisis calls involved individuals who were less than 18 years of age. So again, it goes back to what I said earlier about we're seeing the fastest expansion or growth around children in our system. And so the amount of crisis response and challenge that is manifesting was just in these 2 counties was sort of pronounced as we look at a 65% rate for those under 18. The highest number of calls were coming in as well during the months immediately before summer and immediately after summer. So when you looked at which months had the most calls playing out. The most common causes of the presenting crisis being reported during the initial calls were one or more of the following. So mental health symptoms was reported in 38% of all calls. Self-injurious behavior was reported in 33% of all those calls. Physical aggression was reported in 25% of the calls. Suicidal ideation in 22% of the calls, and aggressive behavior in 18% of the calls. So again, when you think about the complex population that I've been referencing, those areas of concern are not surprising, right? That those are the things that are precipitating someone seeing this as a crisis and wanting that mobile response to support them. The most common psychiatric diagnosis reported for individuals was attention deficit hyperactivity disorder, 33% of all the cases. And the most common IDD diagnosis was autism spectrum disorder, being reported in 50% of those cases. So the final disposition of the cases included home or community stabilization by a responding OMH provider, 44% of the cases. CSIDD follow-up and intervention for 21%, transport to an emergency room, either voluntarily or involuntarily, was only for 10% of the cases, so it was a small number. And then we had about 25% of the cases where there was an unknown resolution that the family or the individual didn't sort of follow up with the mobile crisis after that particular situation. So we don't know totally where that left off. The mobile crisis pilot was concluded in February of this year, and a final report with analysis and recommendations will follow in June. So once we receive that report and the conclusion of all the other projects that were funded through the ARPA dollars, we plan on publishing a report with findings and recommendations from each of the projects so that, again, we can use this to inform future directions. So the other thing that I just want to mention is that I just want to give a quick update on specialty hospital because we have some expansion of our existing specialty hospital program down at Terrence Cardinal Cook. They went from 56 opportunities up to 72 opportunities. So that expansion just was completed actually late winter of this year, so that we're going to be able to receive additional referrals there. And this is specialty hospital really serving those with pretty significant and complex medical needs and IDD. And we also have the Center for Discovery, who will be opening up a new specialty hospital program, we think targeted for the fall of this year. That will be an 18 opportunity program, and it will have 6 of those beds targeted to individuals with medically fragile support needs, and then 12 of them for a neurodiverse population who also has a comorbid intense medical need. So again, this is a new resource in the system. So again, goes back to that continuum of care and how we're really trying to build more options in the system to meet the needs of the complex individuals that are presenting. So I know I gave a lot of information. It was pretty dense. I apologize for that, but I also wanted to make sure that folks are hearing about the many projects and cross-agency activities that we have in place, because again, this is not a single agency solution when you really look at the complexity of needs of people that are presenting.
I hope that there can be further expansion, because I'm sure there's demand there, given the statistics that you gave, which were completely shocking to me about the growing number and how quickly the number of individuals under 21 is growing. So there's clearly going to be. Are there questions or comments? Kristen.
I echo Courtney's comments, Jill. Thanks very much for all that information. It's very encouraging to see all the cross systems work that's happening. In my former DOH capacity, we heard a lot from the hospitals, as you can imagine, about not only the numbers of individuals, particularly the youth, but the length of stay in the hospitals, where the acute medical setting really is not the place that their needs are going to get addressed. And my other big worry, obviously, when you have youth in an acute care hospital setting like that for prolonged periods, is not only that their mental health and behavioral health issues are not being adequately addressed. No disrespect to the hospitals, but also their educational needs obviously are not being addressed as well while they're in that status, and so they're kind of losing ground that way as well. So thanks for all that information. With regard to the intensive residential treatment program that's happening, are there plans to expand capacity? And what's the average length of stay in that residential setting?
Mm-hmm. So it's a great question. So in terms of expanding capacity, their capacity is at 12 beds at that specialized program. And we've pretty much, I think, maintained a waiting list almost for the entirety of the program since it's been operational. The length of stay was intended to be between 6 to 12 months. I will tell you it has been longer than that. Some of that having to do with discharge planning challenges. The goal is for the child or adolescent entering the program to have a discharge plan at the point of admission. Sometimes those discharge plans were back home with family, for example, and the family was unable to make good on their commitments, shall we say. So that created some longer lengths of stay for certain individuals. There were also some coordination efforts because some individuals had a disposition of going to a residential school setting. So we had to wait and do time sequencing to ensure, there was an appropriate transition plan to go to that longer term setting. And other individuals did transition home. So I think the average length of stay, I didn't look at that data right beforehand, but I would say right now we're at about 12 to 14 months. Sarah, is that sounding about right to you?
I think I can provide a happier update there. So
Good.
if you do look at the entire length of the program, I think the average length of stay because of some of those outliers is higher. However, if you look at about the last year of data, I think a lot of the processes have solidified a bit, and we're actually under a year and even closer to about 9 months or so. And we've actually seen many young people, not every single one, appreciating the complexity, return home successfully, reintegrate into school, reintegrate into the community.
Yeah.
Very tired. The thing I see in my work is special ed training. A lot of these kids are in crisis don't know how to. They call the police. And they try to say, well, maybe we have to replace them. It's not their problem. It's me. It should be other service. And I'm from a Chris yelling at him. These districts aren't following the law. Then when these kids are in these places, they get 2 or 3 hours a day of education. Schools often don't deliver them in the hospital, so these kids are falling further and further. So we need to figure out a way to make the school system work better, maybe better agencies. Everyone, finding them right, they still have to provide a law. A lot of this is coming from bullying. I find that the kids on the spectrum get bullied. They react, and the other ones are going to the hospital. The bullying will turn on their own protection. That could be violent. There are stories of kids on the spectrum and are thinking of bringing down to school, take care of their own citizens.
Yeah, it's an important issue to raise awareness about what's happening. Definitely. Chris, I think you had a
Yeah, I
question.
just wanted to make a quick comment. Jill, I thought your presentation was great. Is this on? Is that working? Yeah, I just wanted to thank you for the presentation and just want to underscore the importance of the continued cross-agency collaboration that needs to happen. We're seeing the same thing in the state education department. This population is very complex population of students. There's just not the capacity in our statewide continuum. And, we're a lot of efforts going into resolving that problem, and we just need to continue that. And I just want to thank you for the presentation again and for stressing the importance of the cross-agency collaboration. So we're also seeing the need for intensive treatment type programs for students, and we see that those are costly, and we're still working to, continue to advocate for the rates needed to support those programs because we really do need them, not just in the small pockets we have, but more statewide.
Just they don't exist in New York. It's being sent out of state.
Well, I mean, I think there's efforts underway. I think, yes.
Yeah. I think we do within New York State have some really strong residential school programs. I think our challenge has been, and again, our agency has to take some ownership of this with the flow after those youth are aging out, having access to appropriate adult in-state service options. So that has created the ability when there's no capacity within New York State for kids to then have that referral out of state. So again, I think it's a multi-pronged problem, but we do, and are working on some additional resources to support getting kids, I should say now young adults, out of residential schools when they've aged out. Okay. Yep. So we are working on creating some additional programs in our continuum of care at OPWDD to support getting young adults out of residential schools when they've aged out. Those are a new program that we've just started and have opened up 3 locations so far, comprehensive adult transition homes And again, our focus there is to repatriate young adults who've aged out from out-of-state schools and or from in-state residential schools to then create that capacity within our in-state schools so that kids are not having to go out of state. So again, this is a new program model. Our focus being on, again, a transitional model to get the young adult out of the school setting, which often tends to be a very much a campus-based more institutional, I'm using air quotes, type of setting, not a lot of community integration and engagement, bringing them back into what is a very well clinically supported, staff supported group home setting that is based in a community, working on those community engagement skills with the person, and then working on getting them to what will be their long-term adult service option. So again, this is intended to be more of a transitional model to help address that flow issue that where we have those individuals who are stuck that have aged out of residential schools. So again, I should be able to give more detail on that a year from now when we have some better data. We literally just opened some of these programs and have returned some young adults either from out of state or some in-state graduates to those programs. So that's, again, looking at this in that broader continuum of care need that we're working to address. So.
Yeah, I don't want to jump to any assumptions, but it sounds like a lot of this focus is under 21, and I get it, totally understand it. But I think what it's creating is a larger gap for those over 21 that need the same services, especially in the self-direction model where they're very limited on how they can work with people in a self-direction model from a crisis situation. Because the lack of training, they're not allowed to use skip in a self-direction model. So it's creating a bigger gap. And I had my own experience where one of my sons had to be returned from a self-direction model back to the home because they couldn't provide behavioral supports. That is becoming a bigger and bigger issue within that self-direction model. And the self-direction model continues to grow and probably in 10 years will dominate versus certified settings. So I hope there's more conversations on what we can do in the self-direction model for those over the age of 21.
Yeah, it's an interesting observation. And I think what you're referencing are the allowance of certain types of interventions that can be used in a certified setting where you have a lot more oversight and safeguards in place versus often, I think self-direction is more focused on people having services and supports in their own home where there's not someone necessarily providing a level of rigor of oversight. And then if you're using a more restrictive or intrusive type of intervention, those are things that can be unfortunately misused.
Sure.
And having the safeguards in place is obviously an important consideration. But certainly understand the concerns. I do know that things like our CSIDD program are available to people and it really are strongly intended to support people who are living more independently or with their families.
How do you access? I'm sorry, I wasn't even familiar with it. How do you access it?
Through our regional office. So every regional office has a CSIDD lead. So you just reach out and we can, make the referral to the programs. So again, we now have statewide representation for the model. So, and I know for sure in Long Island, we have CSIDD program in place and they have a resource center. Yep. But very good points.
Great. Rob.
Just a quick question. Jill, thanks for your presentation. Appreciate it. History and rearm is incredibly complicated. I'm wondering, I hope this isn't a possible question, but we're struggling with workforce. Right? Is there any kind of pilot or event how
Thank you, Rob. It's a really great question. And really, how are we preparing our workforce to have the knowledge, skills, and capacity to work with a more diverse population is, I think, really critical, no matter what type of setting that they may be working with our individuals in, whether it's certified or under a self-direction model, things of that nature. There's a whole host of materials on our website around what we're doing to really enhance our direct support capacity and training and certification and credentialing. Unfortunately, I'm not the real expert in that area, but we have a great deal of information on our website. We have a new campaign as well. Alexis, it's hashtag. Okay. Anyways. Thank you. Hashtag more than work, directsupportcareers.com. So again, a whole new campaign on our website and really intended to not only draw attention to the benefits of working as a direct support professional, but then there's also a great deal of work that we've done on micro-credentialing program models and working with BOCES and SUNY system to, again, increase the skills and capacity of our direct support workforce. So there's been a huge undertaking in the area, and I'm not doing it service right now, unfortunately. But again, I really urge you to go to our website because we have a great deal of information on there. And that could be a wonderful topic for another meeting by the proper expert. So not me.
I don't see any more hands in the room, so really great presentation. It was comforting to me to know how much you guys are doing in this area and how much cross-agency work is happening. So thank you.
Sarah.
Yeah, great.
Yeah.
So as Dr. Pettinger mentioned, there are a number of models that are out that are co-planned, co-designed, both with OPWDD and other agencies. But I'm limited in what I can say about them. But I wish I told Jill if I could have come to the meeting before this one or the meeting after this one, we could have talked much more freely. But if you just Google Office of Mental Health Procurement, you will see a number of them. And I hope you could pay particular attention to the ways in which the questions or the scorings really ensure access to quality services for dually diagnosed people and their families. So I would encourage you to take a look. And then when we're out of blackout, more than happy to talk at length about any of these program models, including some, I think, exciting new program models where New York State is really on the forefront.
Okay, great. Well, I know we have a couple of quick updates before we do that. Usually I think we had a robust question and answer and discussion around both topics today. So I don't think we need to open it up much further. I did hear two topics for future meetings today. One was about self-direction and the model for people over 21 and the flexibilities that might be needed in that. And the second was around the direct support professional, the workforce, the opportunities for career advancement, perhaps other opportunities for certain certifications if you're dealing with complex populations, that kind of thing. So I think those are two future topics, but I'm not sure who I'm turning it over to, if it's Alexi at this point. Okay, great. Thanks.
So in the interest of time, because we're a little over, I'm just going to be very quick here. So for the New York State executive budget, it was passed. It was a little late this year. It wasn't April 1st, but it has been signed into law. There's nothing directly pertaining to the Autism Spectrum Disorders Advisory Board within the budget. So there's nothing that you all need to worry about in terms of your terms or any rules related to this board. Additionally, legislation relevant to the board. There's a bunch of proposals out there right now related to autism and maybe creating an autism council, but none of them have gone through committee. So at this time, I don't think it's worthy to bring it all to you guys. But if there is a bill that is moving forward and is potentially going to pass, I'll be emailing you guys about it. So you can share your opinions and bring it up at the next board meeting. There is one bill, but it only is in the Senate that would allow purely advisory bodies. So just like this board, to instead of having to fully be in person, it would allow a lot more flexibilities with virtual, but it has no sponsor in the assembly right now. So I'll let you guys know if that moves forward. None of them right now. Just the Senate. It doesn't have an assembly sponsor. The video conferencing one? Sorry? No bills right now are close to passing either chamber that are related to autism. I will keep you updated if they do.
My bill
Sorry?
is sponsored in both chambers, but it's not specific to autism.
Yeah, sorry. I was just tracking the ones related to autism, but we can definitely talk offline and I can track that one for you as well.
Do you know anything about A08548, and that's the Senate bill about insurance coverage.
Just repeat the number one more time.
It's A08548. It was sponsored by Abenanti. Co-sponsors are Simon and Jensen regarding the,
Abenanti's not in the assembly anymore.
well, that's, I just looked that up, so.
Yeah.
But it's about insurance. So it would be covering things like DIR floor time in addition to ADA, which is basically the only game in town right now for New York State. And as Dr. Jill Pettinger said earlier, we shouldn't be using a one size fits all. So I'm wondering if this board is doing any work around that, or if there's any talk around that, because it's been 3 years. And I feel that as somebody that is a DIR floor time practitioner and someone that's neurodivergent, that it is a respectful and appropriate intervention or support for people on the autism spectrum. And you talk about all these behaviors that we see in kiddos and classrooms and in spaces, and those behaviors are happening because they aren't being properly supported. It's not magic. And if we are properly supporting people on the spectrum, we are going to see a lot less of those mental health issues. I know I had all of my mental health diagnoses before I got my diagnosis that I needed. So I think that it's really important that we start looking at that, because kids deserve agency and we need to start presuming competence. And I would love to see someone on the board that is non-speaking.
Yeah, so I fully apologize. I'm unfamiliar off the top of my head with that bill, but I'll add it to what the board's tracking. And if you want to send any materials on that, I can send it to all the board members and ensure that they're educated.
Thank
And we
you.
can maybe include that in a future board discussion.
I'd love to talk about that. I'm a special ed attorney, and it's an issue in the special ed world, ABA versus floor time.
Well, and interestingly, right, I'm a New York State certified teacher, and I pulled myself out of the system because it's so traumatizing to people like me growing up. So I have my own business now. So now basically what I do is I support kids that are being traumatized by school systems, by other systems.
We should talk.
So I think it's super important that, we start thinking about having, like I said, people that have more intersectionality on the board. Sure.
With the budget, the one thing I wanted to add was, I have heard concerns from people in the independent living and disability communities about the whole, and I don't know enough about it, fiscal intermediary and home and community-based services situation. I see Greg shaping his head. I'm sure you guys are aware, but I think it's at least worth mentioning.
So I'm not prepared to give an update on the specifics of the executive budget right now in this meeting, but I can definitely send that out to the board by the end of tomorrow.
Again, I don't know enough about it, but I know people have expressed concern.
Yeah. So we only have 8 minutes left to this meeting, so I just want to quickly get through some stuff so we can hopefully have public comment. Can you switch to that slide, please? So as you all know, we did the neurodiversity flag. The board requested about $9,000 in funding from OPWDD to receive some materials to help with the advocacy of the neurodiversity flag after hosting the contest. So Josh and Grace have been working on a draft plan on how we want to utilize these materials. So we've gotten it back down to flags, pins, stickers, magnets, and posters, and have identified that they'll be distributed to elected officials, chairs of the committees in each house. But wanted to ask the board members, and you don't have to answer now, feel free to email me. There's going to be a bunch of materials for you guys to have personally and utilize how you so wish. But if you think of any other providers or events or different folks who might utilize these materials, please share, and we'd be happy to include that in the plan and make sure that that gets out to every corner of the state and wherever you guys are working. So appreciate your help on that. Just in the interest of time, I want to move to the next slide, please. So Courtney, I'll defer to you. I know we still have to open up some public comment, but do you want to do an open board discussion? Thoughts?
I don't think so. I think we were pretty thorough today, so
yeah,
it was good discussions.
This is great.
Actually, I don't think. I'll send it to you. There is going to be a big forum on autism and water safety that is organizing with a couple other people between the Red Cross, Y, a whole bunch of all those big agencies. Don't know when it is, but I will share it, the invitation for it, so people can join in, and it'll be kind of talking about, you know, the number one cause of death is accidental drowning. So there is a focus in different agencies on that. So yes, it will be a virtual forum. There is talk about at some of the aquatic conventions, we're also going to try and convene it. So there's actually a new buzz around it. It's pretty neat.
Okay, so for public comment, if you would like to speak, you're going to raise your hand. It's the button on the bottom to the right of share. And at that point, we will call your name and you're going to get a request to unmute, which you can unmute yourself, and that at which point you can speak. We're going to time everyone's comments to 3 minutes. Please note this is not an answer and question period. So folks aren't going to be able on the board to be able to answer your questions. It's more for commentary and anything you want to share with the board. And raise your hand now if you would like to comment. So Anthony T, you should be getting a request to unmute. Anthony, it looks like you're unmuted. Can't hear you though.
I'm a parent of a 20-year-old son who has autism and is a non-speaker. I'm an advocate for all people with autism and have previously offered public comments on numerous occasions at the NIH Interagency Autism Coordinating Committee. My comments will focus on the following 3 themes. 1, harms related to unbounded scientific advocacy. 2, the need for scientific due process. And 3, a call for cross-disciplinary research in autism. Unbounded scientific advocacy. Conventional wisdom allows us to reasonably assume that an increase in scientific knowledge would lead to improvements of the human condition. However, disagreements among some members of the scientific community have given rise to an unbounded form of scientific advocacy that attacks individuals with autism who use communication methods that certain advocates claim lack scientific validation. These professionals fail to recognize the appropriate interplay between science and communication rights. Unbounded scientific advocacy limits communication rights, deprives individuals of their dignity and autonomy, and represents a form of science and its greatest discontents. Theme number 2, government research position statements must incorporate scientific due process. In an environment where scientific advocacy campaigns are on the rise against certain modes of communication selected by nonverbal and minimally verbal individuals with autism, inappropriate outcomes are likely to arise when scientific research is conducted by governments without offering protection of due process. The issuance of government research position statements without adherence to scientific due process fails to acknowledge and balance competing interests, fails to recognize the existence of many research gaps, and will likely serve to further fuel inappropriate scientific advocacy tactics. New York State, including OPWDD, would be well advised to ensure that all scientific position statements incorporate scientific due process methods. Finally, making the case for cross-disciplinary research for autism science. NIH has recently adopted a comprehensive cross-disciplinary approach to science when it comes to Down syndrome. The NIH project is called Include, and its project research plan recognizes the involvement of multi-organ systems in Down syndrome and its co-occurring conditions, and this effort will appropriately take advantage of the full range of existing resources across NIH, integrating the expertise of at least 18 NIH institutions and centers. I recommend that New York State seek to fill the many research gaps that exist by adopting the include model that incorporates a needed cross-disciplinary approach to
Please wrap
autism
up your
research.
comment. You're right
Thank
at
you.
15 minutes.
Thank you very much for your opportunity.
Thank you for your comment, Anthony. Crystal V, you should be getting a request to unmute. Looks like you're unmuted. Crystal, we can't hear you if you're speaking. Okay. Mary H, you should be getting a request to unmute.
Can you hear me?
Yep, we can hear you.
Okay, hi. I just would like to comment that with the ending of the federal what do you call it, the Affordable Connectivity Program, in order to really help people who are sponsored to be in their own homes that aren't certified homes, has OPDD, I'd like that OPDD or the state would consider providing some assistance for the cost of internet services for the individuals they serve. Because right now that federal program has ended, and the internet bills are back to the full price. And in order really to access a lot of these home enabling things that were talked about today, you really do need the internet. So that's my comment.
Thank you, Mary.
Okay.
Appreciate your comment. It doesn't look like we have anyone. Oh, we have one more. Rhonda F. Looks like you're unmuted now, but we can't hear you if you're speaking.
Hi. Oh, no.
We can hear you now. You're good.
Oh, okay. Hello. So I was listening. Thank you so much for everything you guys do. In general, when I participate in these things and I listen, it feels to me, and I can't tell what OPWDD really wants to do with this, but well, I kind of can guess. There's this move to self-direction, which somebody was alluding to before, and I'm just so concerned about that. That sort of sounds like we've made some sort of a decision. We have on one end these crises that are popping up. I'm a psychologist and I have a 38-year-old son with autism, by the way. And I see a lot of people in my community with disabled children who are adults now and some that are younger. We somehow think that self-direction provides people with an opportunity to live where they want. But you're talking only about those individuals who are verbal. Maybe they say they want to live at home. Maybe their parents are going to die in their 70s or 80s. I just think we are not looking to the future. And with my son being 38, he does live in a group home, but I think he was the last person to get into a group home in the state. I just think unless somebody dies somewhere, families can't can't make that happen. And it's unsustainable when people need a lot of support and help, and saying self-direction, people that you can pay to show up for a bunch of hours a day or two, there's not the kind of consistency that is needed. And I'm not suggesting, hospitals like in the old days or institutions, but we had a system of group homes and agencies that were managing them and people that were getting jobs there. And I know locally where I live, there's this, people are pretty aware that they can get paid more if they go work with an individual doing self-direction as a, I don't know what word I'm searching for, but rather than get hired by an agency. And that's of concern. So we have this shortage because there's not enough pay for the people that we need in the houses or the day programs. And then on the other end, so I don't know what we're doing, and that's a concern to me. I know I'm all over the place with this with my comments, but I think if a OPWDD really doesn't want to ever provide housing or services the way they were in the 20 years ago, they need to come clean with that and just say we want parents or siblings or,
You're
we have
right
all
at 3
these.
minutes. Just want to give you a warning and
Yeah,
ask.
I'm going to stop. It's of concern to me because I hear this both ends. People should be in the community, but the community doesn't know about this. It's hard to do that. And I guess that's all I want to say. I'm concerned about the self-direction being the only thing we see in the future, and emergencies, how to deal with emergencies. Thank you very much. Thank you.
Thank you for your comment. I think that is it for public comment online. There was no one here in person in Albany for public comment. So I'm going to turn back over to Courtney to adjourn the meeting.
I think we're ready to adjourn. We're already over time. So thank you, everybody, for your time today and great presentations. Have a good couple months. We'll see you again soon.
Thank you. Have a good day.